These typically need to be decreased by 10%. In terms of getting a good treatment plan, there's a host of things that you can do, from obviously changing your dose volume constraints, adding your number of beams, orientations, tuning structures, collimator angle, isocenter placement, beamlet size, intensity levels, and direct modification of intensity maps is another way to get an acceptable treatment plan. It depends on what's being required. So does more beams equal a better plan? In general, yes. And I think there's at least one paper in the literature showing that tomotherapy is getting even a more conformal plan than you can with 9-field cone beam treatment plan. And that's shown, you can see that a little bit in this slide, going from 3-field to 5-field to 7-field, where the conformality, just in a global sense, the conformality of the isodose curves and sparing of the normal structures is better in the 7-field plan than it is in the 3 or 5-field plan. This number of fields has to be balanced against how long the treatment time is going to be too. If you're going to have a 9 or 12-field IMRT plan, can the patient be expected to lie still on the table for that length of time? That's something that needs to be decided on a case-by-case basis. In terms of beam orientation, coplanar versus non-coplanar, you have to ask yourself, what is the ease of setup? Nowadays, if you're doing image guidance and you have a KV imaging system on your planning, on your linear accelerator, some of the implementations of those require that the table be in the standard position, 180 position. So that may be an argument against not using non-coplanar fields. And then, of course, equispaced versus selected beam angles. You have to be careful about having a standard equispaced beam orientation that goes through immobilization devices may give you problems with the dose distribution that you don't even see in the treatment planning system. So those are things that should all be identified as you're commissioning your IMRT.